Good morning, everyone, again. We will be talking about a very interesting topic. As you know, a major part of what we do in hematology is driven by lab results, often unexpected finding on a routine test. So sometimes patients may present with bruising, but they may not had any bleeding issues, and suddenly you see a significantly prolonged PTT. And usually the first thought might be a common issue, but what happens with the mixing study doesn't correct, right? So that's what we enter the world of the acquired hemophilia A diagnosis today. So today we are going to dive into this particular case. It's a rare autoimmune disorder where the immune system, for reasons we will explore, develops a neutralizing antibody against factor VIII. So it's a great privilege to have Dr. Rajiv Pruthi with us today. Dr. Pruthi is a consultant in the Division of Hematology and the Director of Hemophilia Treatment Center, Mayo Clinic. His expertise in both clinical hematology and laboratory medicine gives him a unique perspective on the molecular pathology of coagulation disorders. So thank you, Dr. Pruthi, for joining us today.
Thank you for the opportunity. Hopefully everyone can hear me.
Yep, we can hear you. So these are the objectives of our talk. And I'm going to start with the clinical case. A 78-year-old female with a long-standing history of well-controlled Sjogren's syndrome presents to ER with a 48-hour history of rapidly expanding, painful left thigh hematoma, disproportionate to a minor bump she sustained. She also reports new-onset epistaxis and oral mucosal bleeding. Her usual medications include hydroxychloroquine and artificial tears. She denies any prior personal or family history of bleeding disorders. Initial lab, WBC 6.5, hemoglobin 8.2. The previous one was 12.5 6 weeks ago. Platelets 210, PT 12, PTT 98 seconds, and thrombin time 15 seconds. A mixing study is performed, which shows immediate correction of the PTT, but upon re-incubation at 37 degrees for 2 hours, PTT markedly prolongs again. Suspecting acquired hemophilia A, further specific testing is initiated. While awaiting results, the thigh hematoma continues to expand and the patient's blood pressure drops. She requires multiple units of packed red cell. Given her age and severity of bleeding, concerns for thrombotic risk with hemostatic agents are raised, especially as she has a history of arterial fibrillation. She recovers from the acute bleeding episode with intervention, and the diagnosis of acquired hemophilia A with a high titer factor VIII inhibitor 35 beta units and factor level less than 1% is confirmed. The team initiates IS immunosuppression therapy. After 3 weeks of combination therapy, her bleeding is controlled and she is clinically improving, but her factor VIII remains undetectable and the inhibitor titer is still high. The patient family expresses concern about the prolonged treatment and potential side effects. So, given this clinical scenario, based on her presentation, what are the key features suggesting acquired hemophilia A, and what initial diagnosis tests are crucial to perform beyond the routine coagulation panel?
Okay. So the most important thing at this stage is recognition. And, you know, I don't think in the history you mentioned that was she on anticoagulants for atrial fibrillation? I'm going to assume she was. And so if you have somebody on anticoagulants and all of a sudden they're bleeding, there's a tendency to think, oh, it's related to the anticoagulants. But in this case, that's a really long APTT. And for those that take the American ABIM boards for either pathology or medicine or hematology, anyone with a huge hematoma or significant ecchymosis and a long APTT it's a factor VIII inhibitor until proven otherwise. And the challenge in institutions that don't have access to, quick turnaround time for factor VIII activity or mixing studies, it's a challenge. And I can understand that the delayed diagnosis sometimes can be fatal. And so in this case, luckily, the institution did have access to incubated mixing studies and went ahead and did the inhibitor testing. So let's just walk through the first question here. What are the key features suggesting autoimmune hemophilia, and what are the additional tests to consider? So the key clinical features I mentioned is a long APTT, new onset of bleeding, and sometimes it's actually most of the time it's major ecchymosis. I mean, really huge ecchymoses. And these patients are already on, at this age, they're usually on aspirin or clopidogrel or anticoagulants. And there's a tendency to think, okay, it's due to the anticoagulants, so they stop the anticoagulants, which is the right thing to do, but you need to work this up further. So let's take a look to see what additional things you should consider when you see an acquired bleeding disorder. So here, I've listed a few things that you should always consider. They're not necessarily in order of, frequency or importance, although I think autoimmune thrombocytopenia is much more common than, factor VIII inhibitors. DIC, have seen patients present with DIC with huge ecchymoses. So again, the testing there should include the screening tests, fibrinogen and CVC. Acquired von Willebrand syndrome is also quite rare, but if patients already have an underlying monoclonal protein disorder, lymphoproliferative disorder, or myeloproliferative disorder, you really should be thinking of acquired von Willebrand syndrome. And this is very challenging because you may not make the diagnosis with a PT, APTT, and a platelet count. You do need to order von Willebrand factor assays. So right up front, anyone with an acquired bleeding disorder, that is part of the initial test you should consider. Then you think about autoimmune hemophilia, such as this case, or even autoimmune factor V inhibitors. Now, the difference between the two, for 5 inhibitors, the prothrombin time will also be prolonged. Then never forget that mild congenital bleeding disorders may not become manifest till late adulthood. I've diagnosed patients, the oldest I diagnosed was 82 years old with a congenital factor 13 deficiency. So never forget that it still could be a congenital bleeding disorder. So I think at least my panel, when I order in, and what I advise is when you're seeing a patient with an acquired onset of a bleeding disorder, it's right here on the screen, your CVC, your screening tests, D-dimer, fibrinogen for DIC, and then just send off a von Willebrand disease panel. Now again, for hospitals that don't have access to these tests, it's a send out test. And if you don't send it out right away, you won't get the results. So you may miss the diagnosis of von Willebrand disease. But for institutions that do have access to these tests, this is the panel that at least I typically suggest. Now, I want to mention a unique lab aspect of these reagents. So here is shown the APTT sensitivity to factor VIII deficiency. You can see going from left to right. Okay, so you see on the right side of your screen is the going from right to left. You can see that as the factor VIII declines, the APTT lengthens, but it does not become abnormal. It does not prolong until you get down to about 30 to 40% factor VIII activity. And then it sort of markedly prolongs in a sort of a curvilinear relationship. So the point here is you might get an APTT that's only 1 or 2 seconds above reference range. In a patient who presents with bleeding, don't ignore that. You really should be pursuing that to determine what factors are deficient. And the next slide will be is more of a summary slide. At least in our laboratory, you can see that we always do APTT and PT sensitivities to different factor deficiencies. And you can see in the extrinsic pathway for factor VII, you have, again, it's 30 to 40%. In the final common pathway, it's between 25 to 45%. I think for the factor V, 45% that region is very sensitive. So you'll be picking up very mild deficiencies of factor V. Whether they're hemostatically significant or not is a different question. And then on the intrinsic pathway, you can see the sensitivities to 8, 9, 11, and 12. So the point here is these sensitivities may be different in your institution. And and I think anyone establishing a new reagent or a new lot, at least in our lab, we run sensitivities to every new lot that we get because we don't want to miss any deficiency states. Okay, moving on. This table simply shows you the typical lab test results that abnormalities that you might see in different acquired bleeding disorders. So on the top, you have acquired von Willebrand syndrome. The PTs and APTT commonly are normal, but because you have a low factor, von Willebrand factor level, the factor VIII might be reduced also, and you might get a prolonged APTT, but it'll correct on mixing study. And you can see with fibrinogen, D-dimer, there's no effect. And then von Willebrand factor levels, of course, are reduced. So similar data for auto-8 inhibitors, 5 inhibitors, liver disease, DIC, and ITP. I won't read each row. This conference is being recorded, so you're welcome to look at the slide in your own time. Now,
Okay, yeah.
go ahead.
I'll ask this question because this is very, very interesting for the mixing study, immediate correction. And unfortunately, not every institution will have that different time point mixing study assay. So let's say you did the mixing study and immediate correction after the prolongation that you I'm sorry. So let's say you had the immediate correction followed by the prolongation after incubation. What does this specific pattern indicate regarding the nature of the factor VIII inhibitor, and why is this finding important for diagnosis and making differentials from others?
Yeah, thank you. That's a really good question. And so this slide shows you just on a high level what happens with mixing studies. And in the second column here, you see you have a baseline APTT, and this is just an example that I have. Normally, when you do the mixing study, most commonly there is inhibition. So in this case, I've shown you that it shortens, but it does not completely correct. And you could get a similar pattern with lupus anticoagulant, that you'll get shortening, but it may not correct. So at least with the first step of screen and mix, you may not be able to differentiate between an lupus anticoagulant and an AID inhibitor. However, after incubation, and some labs do it for 1 hour, some labs do it for 2 hours, I don't think it really matters. With an AID inhibitor, it will markedly prolong. And that suggests a type 2 kinetics for the inhibitor. But with a lupus anticoagulant, it might go up by 1 or 2 seconds, but it does not significantly prolong. So that's the mixing study with incubation is used to differentiate between these two inhibitors. Now, are there standards for incubated mixing studies? There's multiple different publications out there looking at the Rosner index, different ways of calculating it. And there's an International Society of Lab Hematology that came up with some guidelines on how to do mixing studies and how to interpret them. And I just reviewed an article that was submitted by a group from the UK that followed their guidelines. And they had patients with AID inhibitors and lupus anticoagulant. And they said that, if you follow the guidelines, you'll miss AID inhibitors. So I was quite fascinated by that. But the bottom line is if you have access to incubated mix, it gives you very useful information, especially if you don't have access to factor assays. Now, I'm going to assume that your institution has access to factor assays, right?
Yeah, we do have.
So we don't do incubated mixes in Mayo. We have it all programmed, it's automated. We have a long APTT that on mixing it corrects or it's inhibited. The instrument reflexively orders all the factor 8, factor 9, and even factor 11 assay automatically because you don't want to miss a diagnosis. I figure with automated instrumentation, why bother with an incubated mix? But each institution has a different approach. And in the older days when doing factor assays was much more complicated and manual, there are a bunch of different types of mixing studies. There's the incubated mix, there's the aged plasma mix, and then there's the adsorbed plasma. So the aged plasma is plasma from which factor V has been aged out, and then there's the one where you deplete the vitamin K dependent factors. And so nowadays, of course, you just program the instrument, it's cheap, it's done. But anyway, the role of the incubated mix is to try to differentiate between lupus anticoagulant and autoimmune aid inhibitor. Now, remember for factor V inhibitors, the prothrombin time will also be prolonged. And what's interesting is we did we reviewed our experience with factor V inhibitors and published it. Factor V inhibitors are not time dependent. So again, if it's just the APTT you're looking at, and you don't have results of the prothrombin time, it could also be a 5 inhibitor. But with a 5 inhibitor, you don't get the paradoxical prolongation after incubation. So I looked at our series. We haven't published this yet. We're still gathering the data. And on the top, you can see of 69 patients, everyone, of course, had a prolonged APTT. And then I broke down the results of the one-to-one APTT mix. Our reference range is 37 seconds. 17%, that's a lot. They corrected into reference range. Now, I looked at how many just went down to our upper reference, which is 37 seconds, 12%. So if you just do the mix here, you might think this is just a regular factor deficiency. And if you don't have access to the clinical information, of course, I think you still will be doing the factor assays in this situation. But since you already have the plasma, you have it on the instrument, you can do the incubated mix, and that'll help. Now, as I said, we don't do the incubated mix at Mayo. Now, 71%, however, were inhibited. APTTs were inhibited. So this is a good frame of reference to keep in mind that 17%, at least in our experience, did correct into reference range. Now, this might be different with different institutions that have different APTT reagents. So something to keep in mind.
Okay. So, I mean, now you are dealing with a hematoma patient, hemoglobin drops. What primary hemostatic agents that should be considered, and what is their respective mechanism? And also, which one would you choose first? Can you a little bit talk about that part?
Sure. So here are the options for management. There's for many years we've had activated prothrombin complex concentrate. It's also better known as FIBA, and that's activated. There's also a unactivated prothrombin complex concentrate, and that's called Kcentra, and that's mainly used for warfarin reversal. Then you have recombinant factor 7A. And there's two products on the market. One is Novo 7, one is 7-FACT. And then, of course, new kid on the block is recombinant porcine factor 8. There's probably a lot more information on safety with the activated prothrombin complex concentrate and the recombinant activated factor 7. Let's just break that down and look at it. And there's no head-to-head trials, which is the problem. There's only one head-to-head trial in congenital hemophilia with inhibitors, looking at FIBA versus Novo 7. So let's look at the response rates in autoimmune hemophilia with APCC. And if you look at the different studies, and they give you different response rates, so varies between 86 to 92%. And there's different dosages that are applied. Sorry, that moved faster than I wanted it to. Now, one advantage of the APCC is it's only dosed 2 to 3 times daily. as opposed to recombinant factor 7, where you have to give every 2 to 4 hours. One caution is, and I'll talk about this later on in the presentation, if you're going to use emicizumab, which is FDA approved for congenital hemophilia with or without inhibitors, you want to avoid FIBA, which is the APCC, because dosing more than 200 units per kilo per day has resulted in thrombotic microangiopathy. So avoid APCC if you're going to use emicizumab. Now, what is the thrombotic adverse event? So if you look at the pooled event rate, and there's multiple different studies, so there's some review studies that actually pool the event rate per 100,000 infusions. So you can see that the confidence interval is pretty wide, but there's 2 to 3 per 100,000 infusions. And the events seem to occur in those with risk factors, cardiovascular risk factors, and use of higher doses. Now, there's a tendency for patients has dramatic bleeding, to use high doses, but that's not necessarily helpful for the patient. So that's APCC. So now you look at recombinant factor 7A, and again, most of the publications deal with NOVO7. I don't think there's much publications on 7-FACT yet. The dosing is between 90 to 120 micrograms per kilo. The disadvantage is you have to give it every 2 hours. Now, the thromboembolic adverse events is about 1.77%. It's hard to compare this number with the per 100,000. I'm not a statistician, but if you have the ability to directly compare the two, it's still indirect comparison. There's no head-to-head trials. And then, of course, you have the new kid on the block, which is recombinant porcine factor 8. Sorry, it seems to advance and on its own. So the advantage with recombinant porcine 8 is that you can monitor factor 8 levels. With recombinant 7 and with APCC, there's no blood test to monitor. Having said that, I actually have used the thromboelastogram to monitor response rate to those drugs. So the response rate, there's very limited study. You can see that there's 53 patients, and this was mainly post-marketing study. But the response rate varies, and the small studies looking between 80 to 100%, with the initial dose of 200 units per kilogram. And then the advantage, though, as I said, is you can measure factor 8 levels and then titrate the subsequent doses. The frequency is you can bolus dose 1 to 2 times daily, and you can use the factor 8 as a guide as to how much to give, the factor 8 assay. You can also give it by continuous infusion. And what I typically do is bolus at 200 units per kilo and start a continuous infusion at 10 units per kilo per hour. And then adjust the continuous infusion rate based on factor 8 levels. Having said that, not many pharmacists are comfortable mixing recombinant porcine 8. Our pharmacists are quite comfortable doing it because it has to do with the stability of the drug in the tubing and a lot of detail. Now, the safety, again, very limited study. The thromboembolism, so DVTs or stroke, 5 out of 53 patients in this study. However, only one was related directly to the recombinant porcine 8. The reason is that the others, the events occurred 10 to 62 days after the last dose of recombinant porcine 8. So 4 out of the 53, they occurred a long time after the drug was stopped. So only one was directly related. The key here, though, is because the patient already has an inhibitor against their native factor 8, you're introducing porcine factor 8, which is similar enough so that you can get hemostasis, different enough initially that it escapes the inhibitor, but surely what happens is there's an anamnestic rise in the factor 8 inhibitor titers, usually between day 5 and day 10 of exposure. And in this study, 8% of patients, again, out of 53, developed the inhibitor against porcine 8. How would you know? Again, you should be monitoring very closely factor 8 levels, sometimes once or twice daily. Or if there's a lack of response to the bolus infusion, you should suspect a porcine 8 inhibitor.
Okay. I think you already mentioned about when we use the porcine factor 8, what lab we should be looking? Anything to add?
Yeah, so I'll just give you an example here. So in the study, I'm just bringing forward what was mentioned, that 8% of people do develop the inhibitor. And so as an example, I have one case here of actually, this was a congenital hemophilia patient with a history of factor VIII inhibitor. He was transferred to us with a head injury, and in his local community, he got recombinant 7, he got APCC, but the subdural hematoma kept reaccumulating. So he was sent to us by air ambulance because he needed neurosurgery. And so when he came to our hospital, we gave him a bolus of now since APCC and recombinant factor 7 did not seem to be working. We gave him a bolus of 200 units per kilo of recombinant porcine 8. We got a very nice response. Now, I was traveling that time and I'd instructed the consulting service to start a very high dose of continuous infusion. I'm not sure why there was some confusion, but they didn't. And his factor VIII level dropped right away. So I was keeping track of things and I called him and you really need to bolus him some more. So finally his levels came up and he ended up on about 10 to 15 units per kilo per hour. And you can see he got through his surgery quite nicely. Actually, on the post-op day 1, as soon as we got this result, we told the neurosurgeon, go ahead with the surgery. And then we managed to sustain him. By post-op day 3, his levels were declining. And by post-op day 5 and 6, I mean, his levels had completely gone down. And so he developed a porcine 8 inhibitor. Now, there are not many labs that run the porcine 8 inhibitor test. Um, so it's even we don't run it at Mayo, so we send ours to either Versity in Milwaukee or out in Seattle. So the standard factor VIII activity assay is based on the one-stage assay, but you do need a porcine factor VIII as the calibrator to know if the patient has developed an inhibitor against the porcine factor. Now, a challenge is that some of our patients, my patients on acquired hemophilia, I am treating with emicizumab, and that's a sort of a factor VIII mimetic. Um, and emicizumab interferes with the one-stage assay. So you really need a chromogenic factor VIII assay based on porcine, calibrators. And there's only one lab that I'm aware of that does this. It's out in Seattle. So my practice in my autoimmune patients on emicizumab or congenital hemophilia patients on emicizumab, once a year, I'm just checking for porcine 8 inhibitors because if they come in with a refractory bleed, I won't have any way of knowing if the porcine 8 is going to work or not. So that's my typical practice.
Just to add here, or just to a little bit open your comment about porcine inhibitors, is this, you said congenital factor 8 or the people who are on emicizumab with or without inhibitors, have they exposed to recombinant porcine factor 8? That's why you're looking for inhibitors, or are they developing the inhibitors for unknown reasons?
Yeah, so when we before the recombinant protein came available, there was the porcine derived product which got taken off the market because of porcine parvoviral contamination. And when we looked at I didn't publish this, but when we looked at our experience years ago, we used to run the porcine inhibitor titer in Mayo. I believe 5% of patients with congenital hemophilia and inhibitors also had a porcine inhibitor. So they were cross-reacting with the porcine product. Now we haven't done that. I have 2 or 3 patients with inhibitors now, and so far testing in them has been negative. So they do not have cross-reacting antibodies to begin with. The one patient that I exposed to porcine, recombinant porcine 8 is this one, and you can see that he developed the inhibitor right away. And he's also now he's on emicizumab. So whenever he comes to me, I actually send off the porcine inhibitor. It worked on him once, but if he has a high titer, I might be in trouble because then porcine 8 will not work. So if he bleeds, I'm just going to have to use either AP. Actually, I'll have to use the recombinant 7 if he bleeds again. The story here was this guy works in a bar and he got into a fight. So I told him to get a new job.
Yeah.
I hope that answers your question.
Yeah. So again, I think this is also we discussed about the bypassing agents, so we have to get into the IST world now. So what is the expected timeline to achieve remission with IST, and what ISTs do you prefer at initial approach?
Sure. Yep. So I should mention before I go into this that you might wonder, okay, so what do I do for the patient coming in with an autoimmune inhibitor? What's my first line of hemostatic agent? I guess you could say that I trained using recombinant factor 7. So that's, it's 2 doses. I just give the 2 doses, achieve hemostasis, and I guess my anecdotal experience is it's 100% of the time that I get hemostasis. And then I switch to, if I'm not going to use emicizumab, I switch to APCC. So that's my initial regimen. So now here you have to simultaneously decide on what to do with immune suppression therapy. I'll just share one paper to read. There was a very nice international guideline that came out from the Europeans. For those that are interested, you could take a look at that. But for many years, the only drugs we had was prednisone, cyclophosphamide, and then other immune suppressive reagents, right?
Mhm.
There's only one randomized trial that was published in the 80s looking at about 31 patients from David Green in Northwestern. 31 patients were given prednisone to begin with. 6 weeks later, 10 of the 31, the inhibitor went away. So that's a 30% response rate with prednisone alone. So that's still the first line therapy. And then for those that didn't respond, they went on to receive either prednisone or prednisone with cyclophosphamide, and a further 30% responded. There were a few patients that never responded. So that's the reality. So to summarize, I generally say with the quote unquote older regimens, there's a 30% response rate across the board. Now, what's new on the block? What is the latest approach? There are 2 randomized trials, one predominantly in Europe, one in Europe and in the US. So it's called the GTH, autoimmune hemophilia, and then there's a GTH AHA EMI using emicizumab. In this trial, immune suppression, you started with prednisone. That's a pretty high dose of prednisone. And remember, you have these elderly patients and they have comorbidities. So it's going to be a pretty tough approach. But in this group, patients received up to 3 weeks of prednisone, and week 4 to 6, cyclophosphamide was added. And then if they didn't respond, rituximab was added. So it was a graded progression of the immune suppression. In this study, and we participated in this, we've enrolled about 3 patients. So it's hard to enroll. Only 47 patients have been enrolled so far. The first line of therapy is emicizumab. It's a bypassing agent. A factor VIII mimetic. Now the protocol said 12 weeks of it. And what's interesting is in Europe, immune suppressive therapy was not allowed, but the protocol in the US said your discretion, whatever you want to use. So there's some variability in the 2 studies, so you may not be able to directly compare the outcomes. The endpoints were new bleeding, bleed-free survival, overall survival, and more importantly, because of the immune suppression, frequency of infections and thromboembolic events. So 2 different trials, 2 different approaches, and let's look at the outcomes. Overall, if you look at bleed-free survival, those that were assigned to emicizumab had a better bleed-free survival than those that were given immune suppression. Not surprising, right? Because emicizumab is a factor VIII mimetic, and factor VIII inhibitors are not able to interfere with emicizumab what it does. And if you compare the 2 studies as far as the adverse effects, You can see the first trial, which was predominantly immune suppression, about 30% of patients got infected, 11 were fatal. That's a high number. As opposed to emicizumab, infections were in 21%, but none of them were fatal. Now, I suspect those that were put on immune suppression along with emicizumab, the immune suppression was short-lived, therefore the infections weren't fatal. Then it's interesting that thromboembolism was more common in the immune suppression arm. You know, prednisone, I think, is thrombogenic, so that may be why this happened. Four were fatal, but no fatal thromboembolic events in the emicizumab arm alone. And overall survival seemed to be better in those who were initially managed with emicizumab rather than immune suppression. So, you know, this is a really tough question because when the patient comes in, you're still working up whether you're dealing with an 8 inhibitor or not. So there's always a delay in getting the results back. So it's not unreasonable to at least start with prednisone if you clinically suspect you're dealing with an 8 inhibitor. How do I approach this? As I mentioned, I always start with recombinant factor 7. I've never had a thromboembolic adverse event. I'm judicious with it. I don't use more than 90 micrograms per kilo, and I space it out. The FDA-approved dose for congenital hemophilia is 90 mics per kilo every 2 hours, but I don't necessarily do that. What I'm doing now is I do give the 2 doses because you have to stop the bleeding, and I right away start the emicizumab. Now, I'll share an anecdote when we were consulted on a patient in the hospital. I was on the consult service, and it was a Sunday, and you know, there was a patient admitted to the ICU. He had injured his leg, and he kept oozing, kept bleeding, and they kept taking him back to the OR for debridement of the wound. And he had a long APTT that people were just ignoring. So when we came by, we said, "Wait a minute, this looks like an inhibitor." So we sent off the labs, and I gave him a dose of emicizumab right away. I was shocked to see that his bleeding stopped. Emicizumab is not meant for acute hemorrhage, but in him, his bleeding stopped. So I think there's something to be said about using emicizumab early. And my approach is not to do this is the standard dosing listed right here. So you give a loading dose weekly for 4, then you can either give weekly 1.5 per kilo or every 2 weeks or every month. I don't do that. I just give him 4 weekly doses. That's the loading dose. And I start rituximab right away. I avoid corticosteroids and cyclophosphamide unless they're refractory. So anecdotally, I've treated about 3 patients so far with this regimen. I've had a 100% response rate. And I think it's the rituximab that makes a big difference, while the emicizumab prevents bleeding. As you're managing these patients, the big risk is repeated hospitalization because of bleeding complications and, of course, infection. And so the one patient I mentioned with the recurrent wound oozing, we didn't want to use steroids because of potential interference with wound healing. So that's why I started rituximab right away. And that's pretty much what I do now for all patients presenting with this.
Okay, so I'll ask my question once you're done with the presentation. So let's continue with this case. So despite the initial IST, factor 8 remains undetectable, and inhibitor titer is still high after 3 weeks. So what will be the next step to eradicate these particular inhibitors, and what factors influence the decision for escalating to alternative therapy?
So I generally don't check the 8 inhibitor frequently. I might check the factor 8 level, but I don't necessarily do the inhibitor. And here's why. Because if you look at the half-life of these inhibitors are IgG antibodies. There's the different subtypes, but in general, they're IgG. And the half-life of IgG antibody is about 3 to 4 weeks. So I don't think you'll see a meaningful reduction if you check it, in 3 weeks. And then the other lab aspect is these are type 2 kinetics. And, with the Bethesda assay, we're supposed to make the dilutions of the patient's plasma until we get to 50% residual, and we calculate the inhibitor titer at that level. Because of the type 2 kinetics, sometimes there's only one dilution that changes, but that when you calculate the titer, it's the same or even worse sometimes. I've had samples where they send from our Mayo Clinic lab clients, they send weekly inhibitor titers. And I can't make head or tail out of that. I kind of call them up and say, can you stop, treat them, treat the immune suppression, and then maybe check it in a month or 6 weeks. My own approach, so this patient was treated with prednisone and cyclophosphamide, and the inhibitor is still present 3 weeks later. If the patient's not having significant hemorrhagic complications or infectious complications, I mean, regardless, I start tapering the steroid and I continue the cyclophosphamide if rituximab is not being used. The challenge with the rituximab is you have to get pre-authorization. You have to go through a bunch of shenanigans to get the insurance company to approve it. So the bottom line is I'm not sure I pay much attention to the 3-week titer. It's more meaningful to check it at 6 weeks or 8 weeks. Now, the clinical aspect is if I use rituximab, and as I said, I'm using it in the majority of patients, I continue the emicizumab right now, and I don't declare rituximab a failure for at least 3 months, because that's how long I've anecdotally observed the inhibitor titer to respond. Now, before emicizumab was on the market, I used to use APCC in a prophylactic dosing. So generally once a day I would infuse it, but not a very high dose. Now I'm just using emicizumab. There's also the complicated aspect of getting emicizumab paid for, because it's not FDA approved for use in autoimmune hemophilia. So the first time I prescribed it, of course, it's a patient with hemophilia. I was actually surprised that there was no barriers and the insurance company just approved it. Maybe it was Medicare Advantage. I have no idea. I'm not sophisticated enough to know. But the patient does have hemophilia, whether it's congenital or acquired. So with the standard immune suppression, I mentioned Dr. Green's study. Steroids alone, it takes a good 6 weeks to really look at the response, so 30% response. At that stage, it's 6 weeks. If there's no or minimal response, then you would add cyclophosphamide, and of those, another 30% will respond. I think nowadays, rituximab is a more attractive option, and anecdotally, there's a variety of other immune suppressants you could use, Imuran, oral agents. One of the challenges with cyclophosphamide and alkylators is that you're dealing with an elderly patient already. Now, does prolonged exposure to cyclophosphamide put them at risk for developing myelodysplasia? So you have to really balance the short-term and the long-term benefit with all these options. Okay. Yep, there you go.
Okay. So I think this is also an important question when you deal with the elderly patients, right? AFib or other reasons the patient needs to be on antiplatelet or anticoagulation. How do you guide yourself for thrombophlebitis once remissions are achieved?
So I touched on the thromboembolic adverse events rate. So I just put this in one table. And again, this is not a direct comparison. It's basically the individual post-marketing or systematic reviews that have been published. Again, my approach is just to use recombinant factor 7 because we have it on our shelves. We don't keep recombinant porcine factor 8 on our shelves because it's rarely used and it'll expire. But we have Cardinal is our supplier, and they're able to get the recombinant porcine 8 if we need to use it, literally within hours. I think we're in Rochester, Minnesota. I think one of their warehouses is up in St. Paul, so they're able to just basically courier it down to us. And I'll be frank, ever since FDA approval, I've only used it once in that patient that I showed you. So my bias, and because perhaps I've had success rate with recombinant 7, I've never had a thrombotic event. I just use recombinant factor 7A. Now, of course, I keep coming back to emicizumab because I think it's a good drug, and clearly with this aged population, there's always a risk with recombinant 7, APCC, and I have to say even with porcine 8, because only 53 patients experience has been published. I hope they keep publishing that so we'll get a better idea. Emicizumab is not a pro-hemostatic agent. It actually is more of a rebalancing agent, for lack of a better term. So I would probably go, if I was afraid of a patient who's had a history of stroke and I didn't want to use recombinant 7, I would go with emicizumab as the prophylactic agent. Now, once you have cleared the antibody and the patient is now does quote unquote normal, then you can go and manage their atrial fibrillation. And if you need to put them on an anticoagulation, you certainly should do that because now their CHA2DS2-VASc score is normal. One of the challenges with the CHA2DS2-VASc score and our aging population of patients with bleeding disorders is that bleeding disorder does not factor into that. They might have a high CHA2DS2-VASc risk, but if they also have hemophilia, does that annual risk of stroke apply to that patient with hemophilia? We don't know. And so we're still struggling with the balance and we individualize the approach. With mild hemophilia, we might go ahead and say, fine, the experts say as long as the factor levels between 20 to 30%, you should be able to use it. But with severe hemophilia, we actually put them on prophylactic factor VIII level infusions and then put them on the appropriate direct-acting anticoagulant. I'm actually going to see a patient next week who has an autoantibody and atrial fibrillation and is bleeding. So I have to stop I already told them to stop the anticoagulants, and we'll see if we can manage the inhibitor. So that's the summary here is you have the different event rates. Again, my personal bias for the acute hemostasis, I still use recombinant 7, perhaps in lower doses, but I get them onto emicizumab as soon as I can.
I think we touched upon this part, but when you are concerned about the standard ISTs, maybe you touched upon that as well with the cyclophosphamide in the elderly population, and you discussed about the emicizumab. Anything that you want to add here?
No, I think in my last, again, this is very rare, right? The factor VIII inhibitors. And I've managed, since the beginning of last year, I managed 4 patients. One patient was already on prednisone when the patient was referred to me. So I simply continued it. But the other 3 patients, I did not even put them on prednisone or cyclophosphamide. I just went with rituximab. And really, I can't tell you that every institution is able to approve because of the payers and the restrictions. So I think you can still consider using prednisone, but perhaps for a short exposure. Now, if the patient has diabetes, hypertension, open wounds, underlying infection, you might not want to go with that, and you might want to push to go with rituximab. Now, in one patient that we used rituximab, now it was a congenital hemophilia patient, he kept getting readmitted to the hospital with bleeds. And we went ahead and used rituximab, and the insurance company refused to pay for it. After rituximab, he stopped getting admitted. So I showed them the data. I said, look, the rituximab obviously worked. You have to pay for it. And they did. I think the point being, if the clinicians can justify using rituximab based on the literature, and as long as you word your letter correctly and you provide them with the guidance, with the literature, my experience has been that I think whoever reviews these pre-authorizations, they get it. I mean, even though it's not FDA approved for this situation, they get the fact that you need to get rid of the inhibitor as soon as you can. So that's what I use, is rituximab.
I want to ask the two more questions before we'll get into the last part. So we did not touch based on the underlying lymphoproliferative disorder workup. I mean, when do you consider that? Obviously, if someone has a lot of cytopenias, you will be concerned, or lymphocytosis, you may be concerned for CLL part. But do you have any short answer for that question?
Yeah, one of the drivers of these inhibitors is an underlying malignancy. So the question is, how far do you go? I think I wouldn't go as far as a PET scan. I think you can still do CT scans of the chest, abdomen, pelvis to look for adenopathy, and of course your physical exam, and then the lab test that you mentioned. Now, autoimmune diseases, this patient has Sjogren's, and so we work with the rheumatologist to see if we can provide them with Sjogren's directed therapy. Because if you have a persistent autoimmune underlying condition, the inhibitor may not go away completely. And by adding rituximab, maybe the autoimmune disease will get better as well. Um, then there's the supportive care. If you're on steroids, you got to give the infection prophylaxis, GI prophylaxis, and you're dealing with an elderly patient. Osteoporosis is a big risk. So that's sort of the multidisciplinary approach. And as I mentioned, the atrial fibrillation is kind of making things complex for us.
Yeah. I think these five mistakes are very well delineated. If you don't mind to go over it, and then we'll get some questions from the audience.
So I mentioned in the beginning, lack of recognition. You have to be able to, it's easy for me to say because I do only coagulation. So when I see a patient, I know it's an inhibitor. But a long APTT with new onset of bleeding, think about an 8 inhibitor. Every lab needs to be able to explain what their sensitivity is of their individual screening tests. And the clinicians don't always know that, right? They might see a 1 second, 2 second prolongation, and they ignore it. That's what happens most of the time. I think there's some responsibility for the lab to be able to reach out to the clinician and say, well, this is prolonged, what's the clinical scenario? And a challenge that we have a big lab practice, and a fair percentage of our 8 inhibitors are sent to us as a lupus anticoagulant test. So a reference lab might do, PT, APTT, it's inhibited, but the PNP is negative, DRVVT is negative, no lupus anticoagulant. They send it back. But really, you need to follow up on that APTT with a factor 8 assay. So that's really, I think, the lab responsibility. And I think switching immune suppressive therapy is too fast. If you don't give it enough time, you need to kill those B cells. The IgG half-life is long. You need to give it some time. And then when the inhibitor is refractory also, there's a tendency to keep putting the patient back on prednisone. So you're dealing with toxicity of the drug or cyclophosphamide. And then in the era of emicizumab, actually, you can sustain hemostasis even in the presence of inhibitors. I have one patient, the inhibitor never went away. Emicizumab luckily came on the market, and he's living with emicizumab without exposing to the toxicity of. And in the older series, before management of inhibitors was recognized, up to 20 to 30% of 8 inhibitors spontaneously resolved. So that's something to keep in mind.
Okay, so we did not touch base on that part. So how do you wean off the emicizumab? Do you simultaneously getting the chromogenic assay in addition to inhibitor? Can you explain a little more?
Yeah, so my practice is only to use the loading dose. So that's 4 weeks of emicizumab, and the half-life is very long. It lasts 2 to 3 months in your system. And hopefully that will give rituximab enough time to do its job. So following the chromogenic 8, if the chromogenic 8 normalizes, you know that the rituximab has worked, or whatever immune suppression you've started has worked. Again, the 4 weeks, I don't continue the emicizumab for a prolonged period unless the inhibitor is persistent.
Okay, but do you wait for the inhibitor to downtrend before you pull back?
No, as I said, I only give 4 weeks of emicizumab. That's it.
Okay, great. So I think we covered most of the part of the acquired hemophilia A. If there is any question from the audience.
Can you just say again how a mixing study differs between lupus anticoagulant and a factor VIII inhibitor?
Right. So with a factor VIII inhibitor, when you do incubated mix, your APTT initially on the initial mix may shorten into reference range. When you incubate it, it will prolong again. But with lupus anticoagulant, that does not happen. It stays shortened or it's inhibited. Again, I've not seen any lupus anticoagulant cases where it actually corrects into reference range. So there's, at least with lupus anticoagulant, in our experience, it's always inhibited. But if you did do an incubated mix, it would not prolong.
Okay, thank you.
Okay, I think I have one more question if no one has any other questions. So you said in the European side, they did not allow the IST on the emicizumab treated patients. Why is that so? How did they eradicate the inhibitor then?
Yeah, it's still in the study's still ongoing. So the only protocol I have is the U.S. protocol, where we were told we could use any immune suppression therapy you want. Um,
Okay. And
Pretty
have you ever used any other B cell directed therapies for previously rituximab treated CLL patient that present with AHA?
no. I know there's another CD19 or CD20 oblutuzumab or something like that. I've never
Right.
used it.
Okay, great. I really appreciate it. Thank you for your time and your expertise, and we look forward to work together in the future. Thank you very much.
Appreciate it. Thank you.
All right.